Good morning, everyone, and welcome to our session today. My name is Karen Kimsey. I am the director of the Virginia Department of Medical Assistance Services, and I've been the director there for about a year and a half, and I've been with DMAS, though, almost 26 years. And so it's a real honor to be here with you today to give you an update on all things happening with our Medicaid program. So I'm going to advance slides in just a minute, but I do invite you as individuals attending this session to please interact with me as much as you want while I'm presenting and ask questions and post them on the chat feature, and then I'll be sure to address them and work on them while I'm presenting. So please feel free to ask away. I really enjoy interactive natures on these presentations. So we'll get started. There's much to talk about that's happening in the Medicaid world, as you can see in the agendas here. We have several items that I'm going to be updating you on, many initiatives that we are working on to best care for 1.8 million Virginians in our program. So as you can see here on this deck, these are high priority items for the Medicaid program right now. Just in particular, I'll talk about a few, the first of which that we are going to be working very hard to demonstrate openness and transparency to our program to show its value, because all these initiatives encompass one very important program that takes care of a lot of people for their healthcare needs. And so we're going to be working on being more open and transparent regarding these program services and initiatives and how our program operates. So look for more on that in terms of the transparency and work that's underway. Also, in particularly areas like behavioral health, I'm going to touch on in our presentation today. Also, our efforts in maternal child health, health equity, what we're doing for adult dental care, as well as our access to care for different types of services. As you can see here, the Medicaid program plays a critical role in Virginia as a safety net, especially during the pandemic, where we now support 1 in 5 Virginians in our program. Since the declaration of emergency during the public health emergency for COVID-19, we have gained over 291,000 new members. These are individuals who have a peace of mind now to know that they have health coverage during this very critical time. Some people may be surprised to know that we have children being added on to our groups, almost 90,000. But that leads to show that people and families were losing their health insurance. And so we're very proud to be here and be available to support these individuals during this time. We were gaining about 5,000 new members a week. Now it's dropping down just slightly to about 3,800 new members, but we're very, very proud to serve, as I said earlier, a critical safety net during this time. We also, as an insurer, play a very strategic role in our vaccination strategies for COVID. So we are working very closely because we have so many individuals who would be counted as vulnerable and high risk for this particular program and the need in terms of the pandemic, that we're working closely with our partners at the health department and also with the secretariats to share data to identify who individuals are who would be at risk and then reach out to them. So the first thing we're doing is connecting and sharing data. And that's a really important critical part for us, and letting people know not only that, but tracking to make sure that our members are getting vaccinated. Right now, we're currently on track with the state's numbers. And so our Medicaid population is flowing very closely to the population numbers that you're seeing daily from the health department. We are also spending a lot of time getting the word out, educating people, giving them information for awareness, and also helping to provide information so they can make the most informed decisions that they can. So we're working very closely with the health department and local partners to get that communication out that's needed to people to make those key decisions. We're also working with our health plan partners for managed care systems that we have, because we're a predominantly managed care state. 95% of all of our members are in one of our 6 managed healthcare plans programs, if they're not in PACE already. So we wanted to work with our care coordinators to do that. And as you can see, care coordination is a critical piece for us. So our health plans are leveraging our care coordinators through their programs to reach our members and educate them and talk to them, and then also help them register if they'd like to for the vaccine, or even helping to arrange for them to gain access to a vaccine clinic and making sure that they have follow-up appointments, checking on them after they have the vaccine to make sure that they need it. Another piece too, the MassVax clinics are very important and reach a large population of people, but some of our individuals are homebound and they cannot leave their homes, or they may have trouble getting to a mass vaccination site and have trouble getting in and sitting and being through that. So we are working with our local partners and also health plan partners and health department and sister agencies to develop mobile clinics and also specialized clinics to reach our special populations, including individuals with disabilities and seniors, and also individuals who are in high-risk areas who may be shy about taking the vaccine, and also helping them to make those decisions. So we're very, very excited to be involved in those strategies right now. In terms of the vision that we have, and I'm going to touch into now on terms of behavioral health, which is a very, very critical part of our system. I'm not sure if you're aware, but 1/3 of our 1.8 million Medicaid members have a behavioral health diagnosis. And so it's very important that we continue to strive to ensure the best system that we have in place to support them and our providers. So as you will see here, we have a vision to enhance our system. And right now, we recognize that our system is currently focused on the reimbursement for services that are really high acuity in need. They're crisis driven and people for the most intensive needs. So it's not as preventative focused as we need it to be, or evidence based. And these changes that we're making now will enable us to get there. So we are working very closely with the sister agency, Department of Behavioral Health and Developmental Services. Our interagency partners are key stakeholders in the system, and our legislative partners as well, to help make this a reality, to begin those changes. Right now, we're in the first phase. We'll have several phases to implement this system. The first phase, beginning this July, takes existing services and shores them up into a more evidence-based model. ACT, patient intensive outpatient, and partial hospitalization are the first few ones to go. ACT is also called PACT program, so you may have heard of those throughout the Commonwealth. So we're shoring up the existing system that we have, and we will also be advancing new evidence-based practices because we want to keep our individuals in their communities with their loved ones. And this is a vision that we're taking to help be there. And we are very, very proud and pleased to be a part of all the stakeholders and key partners in making this happen. So more to come on this. And just for folks to know, I am seeing your questions, and as I can, I will envelop them and weave them in. So I'm very excited to see people asking questions so much. Oh, and Jessica, thank you for your question about how is DMAS addressing misinformation about COVID vaccines in its outreach. And we have worked closely with our partners at the health department and also the key strategy team that's working on it through the Commonwealth on the proper messaging with the misinformation that is floating out there. So we agree with you. We are setting proper channels. We're mailing information to our members. We're having the care managers call individuals. We're also working with communities that they trust, people who they trust. So, for example, for people with disabilities, we're partnering with Centers for Independent Living. Other communities of care, and communities of color, we're working with local faith development partners, faith-based partners to reach them. So there are a variety of different ways that we're targeting reaching individuals and making sure they get the information that they need. They may have a case manager, and so we're also giving that information to them. So the most important point for us, of course, we want people to get vaccinated so they can be safe, but it is entirely up to them to make that decision. We just want to make sure that we do our very best to help them make that decision. So other thoughts and ideas on that are always warmly welcomed in that piece. So for the next piece, also has DMAS centering primary care to lower healthcare costs? That's a great question, and I will lean on that a little bit more and And I'll talk about it a little bit later, but there is a workforce being led at the Secretary's office, with Secretary Carey being the chair, that is looking at primary care and advancements and changes in value-based purchasing models on that. And we are actively involved in those discussions as well, and look forward to making positive changes to better supporting our primary care providers and having better outcomes for our members. Okay, so the next piece that I want to talk about for you all to see is in terms of our the work that we're doing to advance maternal child health. So in Virginia, unfortunately, the lion's share, many pregnant Black women in Virginia have higher mortality rates than, which is actually 3 times more than if you're a pregnant white woman. And so we have got to do better in terms of taking care and supporting our members. And this high maternity mortality is also disproportionately affects women in rural areas as well, with low income. So it's not just an issue in the cities, it's also all around our Commonwealth. And so one of the things we're working on, and so grateful to the General Assembly and our administration for their support on this, is creating a doula benefit that will has the potential to actually change the trajectory of these birth outcomes, give better support to moms who choose to use this benefit. What you see on the slide here is the reimbursement methodology that we created working closely with stakeholders. And one of the few states that are launching this benefit. Expect to see more to come in other states as well, launching this very, very critical service. Another really critical piece that I'm very excited to see here, because it's not enough just to make sure people get the care that they need. We want to make sure it's easier for them to get into the door in terms of gaining access to critical health coverage. Very excited to show you that we've been directed to provide prenatal coverage regardless of immigration status to pregnant women, and particularly those individuals who do not have a lawfully residing status. So that is very new for us, but we're very excited to be partnering and moving on that. So there are some individuals who aren't eligible right now for FAMOUS, which is our CHIP program or our Medicaid program, except that some who are up to 148% of federal poverty level may qualify through coverage for emergency Medicaid, but it's just not enough. So like we said, we really want to change the directory of birth outcomes. So that's where you're seeing the addition of prenatal coverage on this piece. And this will cover them through labor and delivery, and postpartum benefits, however, though, are going to be likely to be limited due to the federal requirements right now. But there's some other work underway on that, and we're partnering with the federal government and also hoping to advance additional care for individuals. But this is a great start. Let me see, Jessica, thank you so much. Here we go. Another question from Jessica. Oops. Oh, it just moved it to the top. Thank you. You asked if DMAS recently increased access to health coverage, lawful permanent residents, but during COVID, we've seen a disproportionate effect on undocumented communities. Are we planning ways to provide accessible, affordable health care for these communities? Yes, we are. As a matter of fact, you may be aware, but we're creating our own state-based health exchange here through the State Corporation Commission, another directive with the legislature in support of Governor Northam's administration. One of the things we're doing in terms of, as we do more to advance making sure people have the great health coverage here in the Commonwealth, we are spending time talking about individuals. Even if coverage is available in the marketplace, it still may not be affordable, or they may still not even though they may not qualify for Medicaid. So you may have heard they're called 1332 waivers, where we help to balance out by controlling the premiums for the marketplace. And those conversations are underway and continuing to be. So it is a very important topic for us. And we continue to advance this discussion at the state level, as well as in local and community regions, where businesses are also actively working with us. And for me, in the Medicaid program, I talk to them about as if, they're providers for us in our system. So I hope that helps, Jessica, in answering that question for you. But thank you. Keep the questions coming. I'm really enjoying this with you. All right. The next thing that I wish to talk about with you, and it's very, very near and dear to my heart and to many of our staff as well, is the health equity initiatives that are underway. And I was at a conference recently where they discussed that Medicaid can be and should be used as what's called the silent revolution to help advance health equity in health and care in general and programs. And I completely agree with them on that. And so you'll see some of the work that's being done underway to reflect those changes programmatically and also inside our agency as well. So you'll see here, we are partnering with the Department of Corrections, Department of Juvenile Justice, and also the regional and local jails. And we've created a process and dedicated a unit in our call center to process only applications for individuals who are institutionalized, in this case, in justice, currently involved justice. So these individuals, if they're incarcerated, we now have a process in place. And we started this with Medicaid expansion. When they leave, before they leave, they will have been screened for Medicaid, been approved for Medicaid, and be assigned a card before they leave. This is really critical and important, especially while we're dealing with the opioid epidemic as well. So we want to make sure these individuals have the very best start that they can by having critical health coverage. I just talked about COVID, the vaccination strategy that we're taking right now, because we do really want to make sure our members have access to, understand, and are able to get to a vaccination site. And it is upon us to help make sure that happens. We are also closely watching the quality measures for our populations in areas that are difficult. For example, just mentioning our focus on maternal and child health, so critical and important. We've got to get the success of moms and babies up. And so that's another justice area for me, to making sure that women have equal access and treatment in their coverage. And of course, access to care. And I'll talk a little bit more about that as well. And you just cannot, I really feel this strongly, you cannot talk it if you don't live it. And so we also looked internally into our own agency. We have a very robust team inside our Medicaid program. It is a minority agency, and we're working very hard to make sure our leadership is reflective of the team who supports this very, very important, critical program every day. And we've also worked to strengthen the workforce in terms of creation of diversity, equity, and inclusion council, and a dedicated staff person who only works on these issues in the agency for us. Huge systems changes, and for us in terms of our system, even as we operated as an agency, looking at our policies and procedures to make sure that they advance health equity for our own staff, because we had to take care of that where we are now. And we've been very pleased to be working on that and have an amazing council of volunteers, of staff who work in the agency, who are willing to dive in and help us with really discussing these tough things. But we also want to celebrate the diversity of our teams and recognize all different celebrations and things that just make us all very unique. And so we've been working very hard to be a more open and inclusive group here at the DMAS. We've also worked to create a strategic plan for how we want to advance these efforts. And we have been part of a state partnership group working very closely with Dr. Janice Underwood, who has been appointed by Governor Northam to head up our DEI activities across the Commonwealth. And we will be working with her in the One Virginia plan that was just passed through legislation and signed into law, to make sure all state agencies have DEI strategic plans in place. So it's quite our honor to be involved in this very important work. We have so much to do, but we are very excited for the track that it's leading on right now. Oh, okay, so one more. So we have so many opportunities that are happening right now. Even in the midst of the COVID pandemic, we are still advancing in the type of care people receive in our benefit. And we're very pleased to announce that we will be covering dental care for all of our members beginning this July. And about 750,000 new adults will have this benefit. And we're working actively right now to set up the networks to have this benefit available, because as you know, dental care is very critical to the overall health of us as individuals And so we need to make sure that individuals, and many individuals have gone, in some cases, their entire lives without being able to access a dental benefit. So it's a much needed benefit, and we're very, very pleased to be finally offering it. And a huge shout out to all stakeholders out there who helped to make this happen, and to our members of the legislature and administration. The next really big piece I'm excited to talk about with you has to do with telehealth. So in the middle of the pandemic, we worked on making 84 plus changes to our system to make sure people were able to gain access to Medicaid, not lose access to Medicaid while they're in there, and then also make key changes to our program to ensure people are getting to their doctors even when we were shut down, and getting the type of services that they need. And as you can see here, telehealth was one of those options that we did. We literally opened it up, audio, visual, as well as audio only, and it was a key saving grace. Providers conducted over 900,000 telehealth visits to Medicaid members alone just during the pandemic for a wide range of conditions. We were just so pleased to see that that really did make a difference, not only for our providers to stay afloat during this time financially, but to our members to make sure that they were actually able to gain access to coverage. One piece of note that I think you might find interesting is Medicaid members tend to have a high no-show rate, up to 27% to doctor's appointments and other visits. What we noticed is a key piece here is that no-show rate decreased significantly, and we're hearing from a lot of kudos and cheering from the provider community, and also from members who have that. So as you can see, we are setting it up so people can utilize their telehealth at home. They can also make sure, right now it's parity up to payment for, so if you use a telehealth visit, it's the same amount as if you went into the office. Now there may be some changes when we keep audio only, but only a slight reduction. The key point here is that telehealth is here to stay. We're clearly enjoying the benefits of that, and there are more changes to come, even to so much so that as we look forward with telehealth, we are already being directed by our legislature, which is wonderful, and our administration to continue to work to make sure these are permanent additions to our Medicaid benefit the way that we have opened it up. So as you'll see, we're going to continue to drill down, make sure that this service is available and that people have equitable access. So for some example, some people may not have had smartphones. Our health plan partners are working to make sure people have smartphones, and then also enough minutes and cell phone data to actually be able to use the benefit itself. So critical, important, these details to make sure people can get in. Also, helping providers with their willingness to continue to offer these services, and making sure that we incentivize the use of it and ensure that it will be certain that a service to remain for us in the future. So as you can see, there are numerous operating principles that we have with this. It has been rapidly scaled. So we know that providers are anxious about whether or not it's going to be made permanent, but please rest assured we are going to work with you and partner with you to help tweak it and make it the way we need to as a system to be successful for telehealth. Oh, we were just talking about this a little bit ago. Jessica, who's in our audience, mentioned this. We are so pleased to announce that we eliminated the 40-quarter work hour requirement. So if you're not familiar what this is, for individuals who are lawful permanent residents, we're only one of 6 states that still had a requirement for individuals to have 10 years of work history. That is much significant and much longer than the federal requirement, which is 5 years. And so we are very honored to put that back to the federal requirement to 5 years, scale that back, and it is going to enable 4,000 individuals who have green cards to gain access to Medicaid. And so excited to be able to continue to chip away. This is a health equity issue, and we are so happy to be able to make this change. It went into effect this month, and just couldn't be more pleased about this. So just one of those wonderful feel-good moments when you're able to make that type of a change. Also, I wish to go into a little more detail about the openness and transparency and showing the value of the program, just like I had mentioned to you earlier. and this is called Project Cardinal. So last year, the General Assembly during 2020 tasked the Medicaid agency, DMAS, with actually coming up with a blueprint. We have two regional managed care programs that utilize health plans. I do wish to mention our wonderful PACE program, which serves programs of all-inclusive care for the elderly, which serves almost 1,400 members across 11 sites. And it is one managed care option for us. But when I talk about this change, I'm not talking about PACE. I'm talking about our regional managed care models. Right now, we have two, like I mentioned earlier, Medallion 4, which covers pregnant women, children, caretaker adults, and then also our Commonwealth Coordinated Care Plus program, which covers our age blind and disabled populations, and also people who need long-term care services. And so for these programs itself, we operated them separately. We've been a managed care state for over 25 years, but we took it a little slowly. First, we added in, we wanted to go statewide with the Medallion program to make sure we had plenty of managed care support and experience. And then what we went deep. We added populations and services. So now we are fully integrated. 95% of our population, as I mentioned, is in managed care, but there is a direction now to continue to be as streamlined and efficient for our program as we can be, to merge these two programs into one singular program beginning next July. So we are very pleased to be on this trajectory and moving forward with that too, because we definitely see a value added for these changes, a value for our members, especially if a member has to transition between the two programs. That can be problematic at times for individuals. And so we want to make sure that it's seamless to them, what program that they're in. And also for providers, they don't have two separate programs to work on with our health plans. We are very fortunate that our health plan partners, the 6 managed care plans, are already in both programs. So as we combine the two programs, there will not be a need to reprocure at this time. We are already fortunate enough to be able to do that right now. And so the providers will be happy because it'll just be one program to worry about credentialing and getting services, and setting up for. And right now it can be a lot for a provider, maybe personal care, for example, who has somebody they're working in MLTSS, but they may be doing a home health work for a Medallion program part. And so they may have different requirements. And that's where we want to streamline those processes and make it easier. It also adds value to our system because we'll be administering one managed care program versus more than one. And it'll give us efficiencies in terms of costs and savings to the Commonwealth for managing that. So we're very, very pleased and excited to be moving along this trajectory. And so let's see here if I can. Oh, all right. This is the next slide, which shows you, and we are running on the theme of Cardinal. So in our efforts to also make sure that our program is open and transparent, because sometimes when people hear the term Medicaid, they develop this sense of thinking that it's a welfare program or it's something that they should not access or use. And so there's a stigma still attached to this program. And we are working hard to remove that stigma to help demonstrate the critical nature of this benefit. One of the things we're doing, and other states are doing this too, is naming a program something that's common and understandable for individuals. So DMAS is a little hard, and sometimes people don't always know that Medallion 4 is their program, or even CCC Plus is. They just know they have Medicaid. Or they may know that they have Anthem as a health insurer, for example, that's one of our health plans, or maybe Virginia Premier as an example. But they really don't honestly know or understand it. So in terms of making it easier to understand, we will also be rebranding the Medicaid program to be called Cardinal Care. And so as you can see, Project Cardinal is part of that lending and moving into it. As you'll see here, this is our timeline of events, our blueprint that we're doing, and we play off of birds in terms of presenting on this piece right now. So you'll see in terms of the laying eggs, we created that blueprint and we presented it to the General Assembly and to our administration, and then we received authorization to move forward. and direction, and also funding support for that as well. One of the things you may have seen if you're out there monitoring the system is we've put out an RFP to receive contractor support to help us with this very significant initiative. So we're very pleased and thankful to members of the legislature as well as our administration for that support. But right now, we're in that work. We're here right now launching and getting that up and moving. And in terms of that's when like the eggs hatch, and we're well on our way. So right now, we are incubating and creating this program and model that's going underway. And we're well on our trajectory for a July 2022 implementation of a singular combined managed care model. Just very excited about this and in terms of moving forward and engaging our stakeholders. And we want to hear from you. What's important to you in terms of knowing what a successful program is? For you, is it looking at health outcome measures? Is it making sure that the Medicaid program is spending funding in such a way that we're, good stewards of taxpayer dollars? To be honest, for me, it's all of that. And want to make sure that we are open and transparent in how this works. So we've been spending a lot of time working on making sure people can go onto our website and look at our expenditures. So we are accountable to you, our stakeholders, and our taxpayers, to making sure we're doing our very best to run this program the most effective and efficient way while still giving great health coverage to our members and supporting the providers who deliver that care. So this is yet again one of the next steps in the Medicaid program to making sure that we're on the right path and making sure that happens for individuals. So at this point, I was going to pause and see if there are additional questions that people may ask or wish to see. I'm going to flow through here just a little bit. Here we go. Russ, and I apologize for missing your question when we were talking about that, but I'm happy to talk with you all about the incarcerated individuals and also give more information on that as well. So Russ is asking, given that individuals graduating from incarceration will have access to healthcare via Virginia Medicaid, are there plans to implement healthcare benefits during incarceration? That is a wonderful question. I'm so glad you asked that. We have been pushing for this. Now, right now, Department of Corrections, and persons incarcerated, you may be aware, but it's all paid for out of the general fund dollars through the state. And so they are always working to advance and improve their healthcare delivery for incarcerated members, because one thing that's really interesting for many incarcerated individuals, and I learned this through Department of Corrections, the first time many of them even have health insurance is when, or coverage, or even get attention for healthcare needs is when they're incarcerated. So there's this huge need that comes when people first enter the system. So they're working very hard, of course, to make sure they take care of individuals. But we are pushing, we are asking, and would like to see the federal government, as particularly Centers for Medicare and Medicaid Services, to work on changes, and also Congress and the administration, with the Biden administration, to look at ways to enable us to cover these individuals more. So now if I'm, for example, incarcerated and I'm an adult or even a child, if I end up in a hospital, Medicaid can cover my acute hospitalizations. We're set up for that already. But what we'd like to do is cover the rest of the healthcare needs. And just like you're asking, and so we are working hard with them and pushing that and trying to see if there are any federal changes that can come in the next few years to enable us to do that. And so the beautiful piece is the door is open. There is an eagerness to have that discussion, which is wonderful and very exciting for us, because these members desperately need that level of support. And the Medicaid benefit also draws down the federal match, of which many of these individuals meet. In the Medicaid expansion benefit, almost all of them qualify in the benefit as adults. And so we get a 90-10 match. So for every dollar we spend, the federal government pays 90%. So it's really in our best interest to push and see if we can advocate to make sure those changes happen in Congress, or even allow for us to pursue what we call an 1115 waiver to cover individuals who are incarcerated. So we use those waivers to test drive or pilot initiatives that haven't happened, and that is definitely an area for us to look at and think about. And that is a group high on our list, very dear to us, wanting to make sure that they have the best chances that they can when they leave for coverage now. So I hope, Ross, that was helpful to you in your questions. Oh, okay, another question here from Kim, and then I'll start moving around. I know Eli is with me, and I will try and move some of the answered questions over in a minute. And so Kim is asking, hey, Karen, how can DMAS work with our MCO to share data in a more efficient form so we can move our quality metrics in a positive manner? Welcoming my thoughts. So one of the things that we are doing, and it's underway, and I'll speak to this particular piece. So we are going to be creating dashboards that reflect quality and posting it on our website soon to come that reflect these measures about not only how well our individuals are doing in the program, but also how well our plans are performing. And in order to do that, we need to make sure that we're sharing data. The health plans provide that robust quality data to us now, but there are also critical components to an individual's care, clinical needs, that we're also very interested in having and sharing information on. So we are actively working here at the Medicaid program as part of our robust data practices to create what we call, it's a system that will contain a module in our Medicaid enterprise system that will hold clinical outcome information, and we'll be able to share it. So if I'm in one program, a health plan, I'm in Optima's program, and I shift to Magellan, ideally, within the next year, that clinical information that was in my original health plan is already safely at Medicaid and will be able to transfer seamlessly to my new health plan. It will also give us at the agency strong opportunities. So our health plan partners are working very hard to stratify and monitor and make sure our individuals are getting the best care they can get. But in Medicaid, we also want to be able to track and follow those individuals, especially if they have high needs and high costs, to better support them. So this clinical information that will come to us through this information, which will flow, the interoperability will flow seamlessly. And as a matter of fact, we're testing it right now with the modules with our plan partners. And so I'm very excited to say that we will have more information to be able to do that. And you're exactly on point. The data is where it's really going to matter. And also in terms of telling our story, I also wish to share, it's not just about the data, it's really also about telling the story of our Medicaid members. And if you wish to, I'll also make sure that I place in a handout for you all coming up a booklet that talks about the faces of Virginia, Medicaid, all these individuals who are on our program, and also it tells the story. So the booklet features each one of these members and talks about the unique needs that an individual has and how the program has met their needs. And we have individuals who have been incarcerated featured in here, moms who had a baby featured in here, people who need long-term care, or just other services, or people who are working and simply cannot afford coverage or their employer doesn't cover it in this program. So it is upon us to share that. But this data is so critical, but also being able to tell the story of how our members are really doing is going to be very important. All right. So this is also to a point where I just was wanting to make sure I left plenty of time for people to ask any additional questions that they may have. And I'm going to circle back through into the questions to make sure that we're not missing out on anything related to that. And in terms of, gaining access to coverage, we're definitely excited about including lawful permanent residents now on that particular piece, and just chipping away and making sure that other individuals can gain critical access to the coverage. One other one I did not mention, and I should have, is for pregnant women and children. We are now going to be adding benefit if our pregnant woman and I had a baby, and I was up to 200% of family poverty level. After 60 days, I lost my health coverage. I'm losing my health coverage. But we know data shows that the first year of a woman's life is very critical after she has her baby, that if an adverse event is going to happen to a mom, that's when it happens. And so we're very pleased with our General Assembly's strong support and our administration to be extending health coverage from 60 days to a full year after a mom gives birth to a baby. And we'll be making those changes soon. So we're partnering with the health, our partners at the federal level to help make this happen. It's a big national trend. Other states are moving this way as well. So we're very pleased because the health outcomes can be pretty severe for a mom the first year as well as a baby. So we want to make sure the moms and the babies are both there to celebrate that first birthday. So that's also something that we're working on as well. Trying to see if there are any other additional questions that folks may wish to ask. I don't see any at this point. So I'll just wait for another minute and move through the other questions and into the answered categories and see if there are any others that you may have. And I am very open and happy to talk about any and all things related to Medicaid. It's just such a labor of love to be here and work in such a critical program that delivers health coverage to all of our Virginians that we have on the program. So any other questions are warmly welcomed. Oh, okay. There was another question that just popped up. Can I discuss, Josh, welcome Josh, can I discuss how DMAS is impacted by ARPA funding and potential for other incoming funds? Oh, that from the federal government. So we received so much additional funding through CARES Act that had to be, one thing that the CARES Act did is it gave us enhanced match for our program for Medicaid, an additional 6.2% in terms of our federal match right now for Virginia, because we are considered a well-off state. We get 50-50 match, but during the pandemic, we've had an enhanced match, which has really been critical and life-saving in making sure we didn't experience any cuts to the program, that we are able to support them and still continue to move forward and all the changes that you're seeing that we're making with the benefits and adding people and new services. So we were very grateful to get that enhanced benefit, as well as the Biden administration still continuing that through the end of this year. Now, we also, and I will get to ARPA in a second, but just wanted to let you know some of the other critical pieces we did with, we did directed provider payments last time to certain providers. We also gave hazard pay to our consumer-directed attendants and caregivers and agency-directed attendants to recognize their hard work during that time. So we distributed PPE to critical members and providers during this time. So one of the things we're looking at with ARPA, there's lots of funding out there to try and help continue to shore up the states. For us in particular, we're going to see an enhanced match of 10% on home and community-based services, which are long-term care services. We're hoping it also means behavioral health. So we're working on looking at which provider groups were not able to benefit as much under the previous support that was provided by our federal partners, and what can we do? So we're working and partnering too with the legislature as well as our administration to determine what those are. More to come soon. There's just been a huge influx of the funding, and quite frankly, we're all just trying to figure out, we're receiving guidance and information from the federal partners, which is very important because we need to make sure as we divvy out this funding that we do it in a manner of which their guardrails require, which can be quite substantial. Sometimes we're still grateful for the funding, but we just want to make sure we do it right. So you will see more to come. Our legislature is actually holding a special session this year, likely to be sometime in June or maybe even early July, to have this very discussion as to what to do with the funding, not only to best support the Medicaid program, but also support all the critical needs that are flowing out there. So in particular, the funding to help with advancing vaccine efforts and reaching our harder to reach groups, or those who may be really worried or concerned, or just simply don't have enough information to make a decision, or just for some reason or another just simply cannot get there if their job requires it, or they may have difficulty navigating. So the funding is also targeting helping states strategize how to best reach people now that we're coming toward the other side where the availability of vaccine now is outstripping the demand. So, we're going to be sharing more about that, and hopefully we'll be moving on making those changes with the ARPA funding very soon, within the next 2 months. So hopefully, Josh, that'll help with answering your question. Let me check and see if there were any others that were asked while I was working on that question. Well, what other policy discussions will be pushed during the special session? So I believe the biggest piece right now is we're still in the pandemic. So the members of the legislature and our administration are also interested in making sure that the providers, people who support our businesses, who are operating, who have been tremendously impacted by COVID experience, continue to have support they need while the whole system is working to open back up. And so you may see some discussions underway from them there related to what else can be done as a system to shore our Commonwealth while we open up from this pandemic. Also, that's the biggest piece that I'm hearing that they're talking about during the special session, is really dealing with the ARPA funding, any outstanding issues that may have come up, but it's primarily driven around the ARPA funding and support related to the pandemic that I'm aware of at this time. Now, having said that, the members of the legislature can certainly, within their discretion, make changes and explore different things, also in partnership with the administration. So looking forward to that. I do feel for them. They've been great at coming back together and also helping support all of us and the providers in the systems of care, and having these special sessions to make sure that all the funding gets distributed in the way that we need it. So huge shout out to them for helping us to help make these hard decisions in terms of what to do. But I'm very pleased to be in the situation to be having to make these decisions as well. Okay, I'm just checking to see if there are any other questions that people may have related to our benefits and changes that we're having. When we talk about the pandemic, you may be aware that we are still keeping all these members on, even during the pandemic, even if their situation changed and they don't qualify for Medicaid any longer. But as we end the public health emergency, we're going to be working very closely to what we do unwinding some of the changes. And one of the bigger ones for us is helping when we have to disenroll individuals from the program. So we want to work to make sure that hopefully we coincide that to make sure that people know where to apply for coverage and get coverage. And then also, because the last thing we want to do is for somebody to lose Medicaid and then not be able to gain access to other forms of coverage. So we're spending a lot of time on that. There's a lot of national discussion underway about that, the best way to unwind from that and also make it as less of an impact to individuals who are on the benefit. So that's another big discussion that you may be hearing flowing around to not only in Virginia, but also nationally, just making sure we do our very best by our members that way. Okay. Oh, all right. So Eli is just sending out a reminder to us that we're ending in just 2 minutes. I just want to take, and I'll look for the other questions, but just really appreciate being here with you all today. And I sincerely appreciate all the questions that you asked. Always happy to talk about Medicaid, the wonderful things being done underway here, and things that we need to improve upon and fix while we're at it. That we are continually striving to make sure and changing to make sure that our members get the very best care that they can and their families, and also to support our providers the best way that we can. And it's just been my honor to be here with you today, and look forward to speaking with you in future reform sessions, and hopefully we'll see you then.